unless you've told them what the gap is. So thank you very much. I think I've sorted out my problem. Yes, cool. So now we can actually look at feedback models, and there are different tools for different settings. And we're going to cover 6 different models. Wow. And we're going to practice at least 3 or 4 of them, or at least demonstrate 3 or 4 of them. So I'll quickly just show you, this is the overview of the 6 we're looking at. The R2C2 model we looked at in the last session on how you manage a registrar who has failed an exam or where you have a really difficult problem you have to discuss. I'll show us quickly again what that looks like. The SNAPS is a way for a registrar to present and ask for feedback. We're going to talk quite a bit about Pendleton and feedback sandwiches. And then we're going to talk about case discussions using the 1-minute preceptor or the ready, set, go when somebody is discussing a case. So if we first look at how to request feedback. So this is registrar driven. Apologies for the spelling mistake there. And the classic model we do is the SNAPS. So I teach SNAPS to everybody. I teach it to my interns. I teach it to my registrars. We mentioned it last time as well. And in your asynchronous learning materials, you will find this sheet that gives you details on what we mean by the SNAPs. But basically, when your registrar comes to you and wants feedback, this is how we want them to discuss the case. So we want them to be able to summarize briefly the history and the examination of that particular case. We want them to narrow down what they think is going on. So this can either be a diagnosis, or it could be a differential, or it could be management things that I've tried, or things that we've sort of investigations that we've done up to date. And where they sort of have to already in their own mind have started committing to some sort of decision on this particular case. They need to be able to analyze and prioritize what that means. So this is what I think is the most likely, but these things I'm not so sure. This is less likely, but I need to make sure that I exclude that. So we want to be able to see clinical reasoning in the way that they actually analyze that decisions that they're making. Then you have what we call a probe the preceptor, and this is actually the conversation. So the registrar is supposed to come to you and say, I think it's this and this and this. I think maybe more this, but I'm not so sure about that. And I was wondering, what do you think? Should I do this first? Or I was wondering about this. So we want to know what their question is to you as the clinical supervisor. Then together, you're going to actually make them the plan. This is quite often the discussion on how we're going to now go forward with this. And then they need to themselves then select, oh, I don't know this particular guideline, or I wasn't aware of that particular thing, and I'm going to go and read up about it. So this is a very nice way to make your discussions a bit more efficient. I find when the interns come, they've written those beautiful medical, medical student notes. Now they want to read you all their notes when they're coming to ask you a question, but we want them to be able to actually illustrate their clinical reasoning when they're asking that question, so that I can then give constructive feedback on that. So that's the SNAPs. And so this is very much registrar driven. So this is not something I teach you to do. This is something you teach your registrars to do, and we'll see that in action in a moment. The next one is doing feedback after an assessment. I'm not going to spend too much time on this because we had an example of that in the previous session. This is the R2C2, and this is to do when you've called the registrar in and you're now going to talk about their lateness, or you're going to talk about a adverse event of something that went wrong, for example, with a patient or a complaint that's come in. And this is a little bit on how we craft that to go from the relationship that we're building, being able to explore their reactions and to what's actually happened, to explore what happened, the content of what happened, and then how we coach them towards performance change. So this is a very particular scenario where we use the R2C2, and that's usually more of those sort of high stakes when things have gone dreadfully wrong. The one we're going to use a lot, and that we're going to be look at in a bit more detail, is feedback after an observation. So that's that thing after you've watched them in a consultation, or after you've watched them in theatre, or after you've watched them present. There are 2 main techniques, and they're actually related. They're sort of the ones actually nested in the other. The one is the Pendleton, which we'll look at. And then the other one is the modified feedback sandwich, which you've all already been exposed to, even if you might not know this. So the feedback sandwich is the classic, you say something nice, and then you say something awful, and then you say something nice. And unfortunately, it's become slightly trite that people literally do that. They will go, oh, well done, you did that consultation in a good amount of time, but and the millions of things that was wrong, and oh, you look lovely today. But the idea of the feedback sandwich is actually about affirming what went well as a way to also give feedback for the future. I want more of this behaviors, and then being able to comment on what they struggled with. And I'll show you in a moment what the modified sandwich looks like. So you'll see the feedback sandwich is actually embedded in Pendleton. And what the Pendleton structure is basically it's giving the learner the first go in terms of evaluating themselves. So say, for example, they've just done a presentation that you've observed, or you've just done a bit of surgery together, or if they've just given an anesthetic, then you might now go into your private space. And now you're going to ask the learner to tell you where they are at. So they can give you a bit of background on what's happened, but the step 3 and 4 is the important bit. So the learner will step 3 and 5, sorry, the learner will actually say, yeah, this is what I think's gone really well. Now, in the Pendleton, the idea is that the learner tells you everything they think they did well, and then you build on that to say what you're agreeing with them and where you may not. Yeah, so yes, I agree, this is what you did really well. And then the idea is that the learner then says, but these are the things I felt I did not do so well with, or the things I struggled with. And then you use that as your stepping stone for giving your feedback. The Pendleton structure is not fixed. There's basically between, and then of course you've got your action plan. But step 3 to 6 is very mobile. Because what I find learners often do is they'll start off, you'll ask them, so what do you think went well? And then they will go, well, I like this and this and this, but, and they will go straight into all the stuff that they've struggled with. And so I would tend to flow a little bit with where they are at. I do sometimes have to stop them and say, well, hold on, no. I really want you to focus first also on what areas you think was your strongest areas. Sometimes they're very bad at identifying their own strengths. But you basically, this is quite flexible. But the idea is first have an understanding of how they've experienced their strengths and weaknesses in that particular activity before you start adding your own comments. And then you use their ideas as a springboard to build on. And that's just a good way of having a conversation in general. And then at the end, there's always an action plan that has to be made. So there's a lot written about Pendleton. And its basic strengths is that this learner having to actually look at their own, reflecting on their own strengths and weaknesses is generally very good practice. They need to start becoming aware. Yep, this is where I know, and this is what I don't know. So that in itself is a skill we want them to build. But also this building upon their observations is actually a very good way to create an opening for you to give input. And also we give strengths and weaknesses, both are important, and it's nice and specific. The weakness is that it can feel like it will take longer, so it takes a little bit more time than the modified feedback sandwich. And as I've noticed, sometimes people just struggle to stick to their strengths and goes into weaknesses almost immediately. And then some people find that this weird flow of getting them to talk and then I talk feels very artificial and doesn't flow nicely. But if you just keep in that basic principles, get an idea of what they think before you bring your comments, you can usually build quite a nice flowing conversation. So this is the modified feedback sandwich that we use in WBA. This is the one we used in our model last time when we did with our WBA, when we filled in our WBA form. So the idea is what was done well. And this is not about just trying to make them feel better to buffer the blow. This is about what do I want them to do more of? Okay, actually, they're really good at doing this. I want them to do more of that. And so I'm just going to remind them that, yep, this and this and this, I want you to continue doing. So with cesarean section, it's helpful to, for example, with surgery, anesthetics, any procedure like that, to also say to them, I really like the way you closed up, for example, your stitching is really excellent. So even finding skills that they can then feel, okay, actually that bit I've got sorted. The important bit is this, what could have been done better? And I agree with Sean, the whole point of feedback is this bit. If you don't do this bit well, then you haven't done feedback. Then we're just having a chat. And then instead of now trying to come up with something nice to say at the end, what you actually want is you want a positive plan going into the future. So this is why we call it the modified feedback sandwich. This is positive, but it's actually an action plan that's going to close that gap depending on the gap that you've identified. So we are going to be using the feedback sandwich as your predominant way of giving feedback in these different exercises. Great. So that means we can now actually get to the fun bits. And the first, we've got 4 different things we're going to go through. The first one we're going to do is a big group. And then the other 3, we're actually going to break into breakout rooms. The first thing I want to do with you guys is the entrustment case-based discussion. So for those of you that might not have been to some of the other sessions, as a family physician and any of you that's got lots of OPD stuff happening, this is by far our favorite way of doing WBA. And at the moment, that is 90% of the WBAs that I do actually falls under EBDs. So there are different ways in how you can structure it, but the core of the entrustment case-based discussion is that your registrar comes and discusses a case with you. You're obviously going to manage that, give feedback on that particular case, but also during that particular case, you're going to basically ask them some questions like you would in an oral. So you're going to extend a little bit and say, well, what would you have done in this scenario? And what would you have done in that scenario? And what do you know about the guideline about this? So you enlarge your discussion, or you ask some in-depth questions about that particular thing. And that gives you an idea of how well do they know that particular topic and can help you make an entrustment case-based discussion. So it gives you an opportunity to both teach something, but also to identify their confidence in that particular topic. The case discussion itself, the model we're going to use, there are 2. One is called the Ready, Set, Go. And then the classic one is the 1-minute preceptor, which I'm going to show you guys today. So the Ready, Set, Go is an acronym. That Set, Go stands for something. And again, it's what you do when somebody's discussing a case. The Ready, Set, Go is that very quick giving advice to somebody when you're in the busy OPD and they bring you, can I quickly ask you about this patient? So they present the patient, and then the first thing you say, well, what did you see? So what was your observations? What is your little summary? It's a bit like that schnapps. And then the next question is, okay, so what else is your observations? What else do you need to know about? So this talks a little bit around your differential, well, not so much your differential, but your history and other investigations that comes into the story. And then teeing out, okay, now what do you think? So you're trying to get to commitment and ask them what they think their next step should be, or what they think the diagnosis is, or what the next investigation is. And very similar to with your SNPs, you're actually forcing them to actually make a commitment. So we quite often, when somebody comes and gives you a little case, you might focus on what their observations was and other investigations and things they've done, and then we want to go straight in with the answer. So this is making them actually commit to what they think. And then you actually ask them, okay, the G is for goal. What is the next thing that you actually want to do? What is your next step? What are you now going to do about this to figure out this thing that you think? And how you're going to actually do that. So that's going into the detail of the plan. So this is just a nice little way of forcing you to get the registrar or whoever's discussing the case to make commitments before you give advice. I'm not going to spend a lot of time on Ready, Set, Go. We're going to put this nicely into the 1-minute preceptor. So the 1-minute preceptor has got there's lots of fun videos on it. When you go and do the online asynchronous, we've got some videos on there as well. And there's actually some very good evidence on its usefulness. And this is about any scenario where somebody comes and discusses something with you. So this could be asking for advice on a patient, but it could also be a nurse talking about a challenge they've had on the ward. It could be bedside mentoring, either in the consultation room or in a ward round setting. So in a ward round setting, instead of just doing like a clinical knowledge, you're actually going to, around this case, have a discussion to actually help the registrar's clinical reasoning. And this is a very good way to help teach clinical reasoning as well. So what does it look like? So you'll find lots of different models. A lot of the models has got 5 steps. There's also a 7-step model. I'll show you the 7-step model. It's got sort of a prep one and a homework bit. So one of the things you can do is when somebody discusses a case, and this is particularly important if it's somebody you don't know very well. So they're a new intern in your department, or they're a registrar that's just started and you're not sure where their level of knowledge is, and they ask you about a case, you can just double check with them first, well, how familiar are you with these kinds of things? But then step 1 of the 1-minute preceptor is get a commitment. What do you think is going on? And so this can either, again, be either differential, or it can be a sort of investigations that they've done or plan that they think of ways of going forward. But yeah, what do they think they want to do? The next thing you want to ask them is, why do they think that? So one of the best ways to learn clinical reasoning is being forced to explain why you think what you think. So that ability, and they've even shown that the best learners out there is people who actually explain things to somebody else. So I've also noticed if I want to learn like the new guidelines, I create a training on it. And once I've done a webinar on the new guidelines, I know the new guidelines. So when you explain something to somebody else, you actually have to understand something. And so sometimes your registrars will have a rough idea if they think, oh, maybe it's this, maybe it's that. Probing them of how they came to those ideas already gives you an idea what's going on with their thinking, but it also forces them to use that clinical reasoning skills. Step number 3 now is the warm and fuzzy. Now we do the what went well, or just agree with them. Yep, I agree with this and I agree with that. Those are the things you've done well. And now you want to identify what the gap is. So sometimes it's something that they've actually done wrong or is incorrect, or it's something that they just don't know or left out. But this is now where you're going to do your teaching. So now you're going to tell your clever bit. And then step number 5 is out of this consultation, coming up with a general rule that you can teach them for the future. So sometimes you've just corrected a particular question that they have, or you've identified the issue. And now you can say, when I see patients like this, this is something that works well, or this is something that you might need to consider. The step number 7 then is what is your next question? And this is about promoting self-directed learning. So now I want you to go home and I want you to go and actually read up about something. So we want to now actually see a little bit how we start putting this all together. So our first exercise is on just getting a bit of an idea of EBD and entrustment. This is not something you're going to do. I have tried role plays before it actually gets quite complicated because somebody has to play the patient and somebody has to play the supervisor. And when you're new to these models, it just gets a bit puzzling, and I wasn't sure how to do that in an online environment. So I'm going to what I've done is my dear registrar has assisted me, and we've made a little video that you're going to watch. It's 6.5 minutes. Usually you can do a 1-minute preceptor under 5 minutes, but we've done a bit of an entrustment-based case discussion in it. So I also probed a little bit some extra questions. So I've asked my registrar to use the snaps to present the case. I've used the 1-minute preceptor to actually structure so as we were structuring the case discussion going forward. So that's my feedback methodology. And this is actually, as a WBA, is an entrustment case-based discussion. So after that discussion, he is actually going to send me a form, and I will do a entrustment decision on it. This was a simulation. We actually had a similar case that he had discussed with me, and then we actually built a simulation out of it. So just that you know, this was sort of a pre-written script. After we've watched the video, and we're going to do that as a group, I want you to make an entrustment decision. So we have found, so last time in the WBA session, we started practicing making entrustment decisions. And we can see there's this challenge of thinking in terms of competency versus entrustment. So we are very used as clinical supervisors to decide how well did this person do and give them a mark out of 10, right? So you do your OSCE and they do whatever they've done, and now you're going to tick, 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 and now they get their little mark out of 10 or 20 or 30 or whatever the case may be. And then that can translate very nicely into a percentage. When we're making entrustment decisions, we're doing something completely different. You are looking at your question that you want to ask at the end of this is, at what level would you trust this registrar to see patients of this kind in the future? So one of the things I find interesting, and I'm preempting it slightly here, is that at the moment, my third-year registrars, we're busy signing them off for all the EPAs, right? So we're expecting them, they should be operating at a level 4. So just for those of you that might not have seen the entrustment levels, there are 5 levels. This is looking into the future. I trust my registrar only to observe this in the future, not to touch the patient. I trust them to do it, but only if I'm actually there. So if you think of surgery, I must be assisting them with that particular procedure. Level 3, depending if it's a surgical or more of a consultation based. If it's surgical, I actually want to be either in the corridor or in the room. I want to be close enough that if something happens, I can be there within a few minutes. Or for consultation-based things, indirect reactive supervision. You should be able to reach a supervisor any time to ask questions about that patient. So our registrars often operate at a level 3 through most of their studies. Level 4 is when they're able to act independently. They can call me if needed, but I trust that they can actually do the job. And level 5 is somebody can actually train other people on that particular topic. So for family medicine, we expect our registrars to get to level 4 in all their EPAs by the end of their training. And what I find is when I do EBDs is that there's always something you can teach. It's very uncommon that I get my registrar. I had one today, though. My registrar was presenting on hypertension, where I could go, okay, no, I know that topic he knows backwards, inwards, outwards, and there's actually nothing I can teach him about hypertension. But most topics, actually, most cases, there's always some little tip you can bring or something extra you can add. And so it's this, from a competency point of view, one can say they never get quite to a level 100%, oh, they know everything. But at which point do I say, no, actually, I trust this guy to be running this particular clinic with these kinds of patients without me even giving it two thoughts. So that's just a little bit of a thought about entrustments, because we're going to do an entrustment on this particular video. So I'm going to play the video now. And then we'll just